Welcome to the deep dive. Today, we're really digging into something fundamental for all of us in vascular surgery, atherosclerotic risk factors.
That's right. We're using Section 2 of the latest Rutherfords, specifically chapters 11 through 17, as our guide.
Exactly. And the plan isn't to read the textbook aloud, obviously, but to pull out the absolute must-know information, the stuff that directly impacts how we manage our patients.
Precisely. We're focusing on the big players: smoking, diabetes, dyslipidemia, cholesterol issues, and hypertension.
Our mission really is to get everyone quickly up to speed on the current thinking and strategies for these key risk factors, straight from Rutherford's perspective.
Okay, let's kick it off with chapter 11, smoking, a huge factor we deal with daily.
Yeah, the chapter gives us some numbers from back in 2017. Overall smoking prevalence was about 14% in U.S. adults then. Lower than it used to be, thankfully, but still significant.
And what's really useful is how that breaks down. Higher rates in men than women, highest in the 45-64 age group.
And big variations by race, ethnicity, education, income. American Indians, Alaska Natives had the highest rates, while folks with graduate degrees had the lowest. It paints a complex picture.
It really does. But the Women's Health Study data they cite is incredibly powerful for illustrating the direct link to PD.
Tell us about that, the dose dependency, right?
Exactly.
Yeah.
Compared to never smokers, former smokers had about a threefold higher risk of symptomatic PED. Okay, significant?
But for current smokers.
It just jumps dramatically.
Yeah.
Almost 12 times higher risk if smoking under 15 cigarettes a day, and, get this, over 21 times higher if smoking 15 or more.
Wow, 21 times. That's massive. It really underscores the danger.
Absolutely. But the flip side, also from that study, is encouraging. Quitting works.
How clearly did they show that?
Very clearly. The longer someone had quit, the lower their risk. Compared to current smokers, someone who quit for 20-plus years had a hazard ratio of just 0.16. Never smokers were down at 0.08.
So a huge reduction. The benefit really builds up over time.
Definitely. But there's always a but in research, isn't there? The Eric Slick study, atherosclerosis risk in communities?
What did that find? Something different.
Sort of. When they looked at carotid intima-medial thickness, a marker for early atherosclerosis, and controlled for lifetime pack years, they didn't see a significant difference between past and current smokers.
So maybe the risk of symptoms goes down with quitting, but some underlying arterial changes might persist longer term based on total exposure.
That's one interpretation. It really highlights the importance of preventing people from starting in the first place.
Makes sense. And Rutherford's reminds us, smoking isn't just PA. It's strongly linked to Berger disease, thromboangiitis obliterans, and aortic aneurysms too, stuff we see all the time.
Right. And beyond the vascular system, quitting improves all-cause mortality. Big picture health benefits.
Okay, so for us, interacting with patients, what's the actionable advice?
The chapter stresses that even really brief counseling, like just a minute, can make a difference. Personalized advice from us.
That's good to know. It doesn't have to be a huge production every time.
Exactly. And they review the 5 A's framework. Ask, advise, assess, assist, arrange. A good structure to keep in mind.
Ask about use, advise quitting, assess willingness.
Assist with a plan, and arrange follow-up. And Table 11.1 offers practical tips for that assist part.
Like what?
Things like aiming for total abstinence, cutting back on alcohol since it can be a trigger, getting support from household members, identifying personal triggers, and preparing for withdrawal. Real-world stuff.
Good. And then there are the medications, FDA-approved options.
Yep, first-line therapies. Nicotine replacement NRT comes in lots of forms: gum, patch, lozenge, inhaler, nasal spray.
Table 11.2 details those, right? Dosages, side effects.
Correct. And it also covers the non-nicotine options. Bupropion SR and varenicline. Explains how they work, dosing, side effects. Important to note the neuropsychiatric warnings with those too.
And it mentions these aren't typically for very light smokers, like under 10 a day.
Generally, yes. The evidence base is stronger for moderate to heavy smokers.
What about combining therapies? Is that effective?
It can be, yeah. The chapter mentions combinations like the patch plus a short-acting NRT like gum or spray, or the patch plus bupropion. Table 11.3 even gives some odds ratios for success at 6 months.
So multiple tools in the toolbox.
Definitely. And the final really crucial point from this chapter is our role. We as surgeons need to be counseling longitudinally. It's not a one-off before surgery, it's part of ongoing care, as vital as the procedure itself.
Absolutely critical. Okay, let's shift gears to chapter 12, diabetes mellitus. The book hits hard right away, saying the main consequences are vascular.
They really are. Both microvascular, think eyes, kidneys, and macrovascular, the larger arteries.
The stats are pretty stark. What were they? 20-fold risk of blindness?
Something like that, yeah, and a 25-fold risk of end-stage renal disease compared to non-diabetics. Plus, it massively accelerates PA, CAD, CVD.
And a huge chunk of deaths in diabetics are from CAD, right?
The majority, yes.
Yeah.
And double or triple the risk of ischemic stroke. Plus, it's the leading cause of non-traumatic amputations, something like 60% of them.
The epidemiology is worrying, too. Increasing prevalence globally and in the U.S., hitting younger people, higher rates in certain groups.
American Indians, Alaska Natives, Hispanics, non-Hispanic blacks, and very common in older adults over 65.
And the basics, type 1 versus type 2.
Right. Type 1, autoimmune, absolute insulin lack, needs insulin. Type 2, insulin resistance plus inadequate secretion, much more common, and increasingly seen in younger folks too, which is concerning.
How does the chapter link diabetes directly to vascular disease mechanisms?
It talks about sustained hyperglycemia, high blood sugar driving microvascular problems, while glycemic variability, the ups and downs, might be more linked to macrovascular issues.
Okay. And the impact on specific areas, coronary disease.
Increased risk, earlier onset, worse outcomes after MIs or stents, more acute presentations, higher mortality post-MI, just generally worse across the board.
And cerebrovascular, stroke risk.
Doubled risk of stroke, often earlier onset, worse functional recovery. High blood sugar during a stroke is also bad news for outcomes. Higher risk of recurrence, long-term disability.
And for Patey, our bread and butter.
It's devastating. Leading cause of non-traumatic amputations, high hospitalization rates. The risk of amputation skyrockets, especially in older patients with both conditions.
The LIPAD study gets mentioned.
Yeah, highlighting the incredibly high cardiovascular event rates and, frankly, the terrible mortality after amputation in these patients. It's grim.
So what's going on at the vessel level? Dysmetabolism and endothelial dysfunction.
Exactly. Those are the key starting points. Hyperglycemia and insulin resistance mess up the endothelium, reduce nitric oxide bioavailability.
Which helps vessels relax.
Right. Then you get this cascade involving adipose tissue, free fatty acids, reactive oxygen species, inflammation. And specifically in type 2, you often see that atherogenic dyslipidemia pattern.
Low HDL, high triglycerides, small, dense LDL.
Precisely. The particularly nasty kind of LDL.
The chapter mentions the WIFI classification too. Useful for diabetic foot ulcers.
Yeah. Wound, ischemia, foot infection. Helps stratify amputation risk.
So when we're treating these patients with diabetes and POD, what are the goals?
Two main goals. Improve the limb outcomes, obviously, but also reduce their overall cardiovascular risk. And aggressive risk factor modification is key, potentially cutting CV events by half.
That's a huge potential benefit. Foot care gets a lot of attention too.
As it should. Recognizing neuropathy, ischemia, infection early is critical. Regular screening, patient education, proper footwear, and of course, tight glycemic control. The ADA, SVS, APMA all have recommendations.
Annual exams, Semmes-Weinstein testing.
Essential stuff.
Then the pharmacologic treatments for blood sugar, lots of classes.
A whole array. Sulfonylureas, meglitinides, TZDs, DPP-4 inhibitors, GLP-1 agonists, SGLT2 inhibitors, insulins. Table 12.1 summarizes them nicely.
Mechanisms, HbA1c lowering, weight effects, hypoglycemia risk.
Right. And importantly, it highlights the cardiovascular benefits seen with GLP-1 receptor agonists and SGLT2 inhibitors. That's been a big development.
The ADA guidelines reflect that now too, right? Lifestyle and metformin first, then add based on A1C and CV risks.
Exactly. GLP-1s and SGLT2s are specifically recommended for patients with established CVD or high risk.
What about blood pressure control in diabetics?
Crucial. Absolutely vital for reducing macrovascular events and death. The ACCH guidelines generally aim for less than 30/30/80 for many with diabetes.
Based on trials showing benefit.
Yeah, like the ABCD trial, specifically in PA patients, showed intensive control reduced events. Though European guidelines, the ECHH, have a slightly higher target, generally 14E90.
And lipids. Still primarily statins.
Statins are the cornerstone, definitely.
Yeah.
But Table 12.2 reviews trials like Improve It and Fourier, showing benefits of adding ezetimibe or PCSK9 inhibitors in certain high-risk diabetic patients.
Finally, exercise.
Important too. Improves glycemic control, endothelial function. Combined aerobic and resistance seems best. The GOIES trial showed benefit for claudication in diabetics. SVS recommends exercise programs.
So Chapter 12's message, diabetes massively amps up vascular risk everywhere, and we need an aggressive, multi-pronged attack on all risk factors.
Yeah, okay. Chapter 13, dyslipidemia, managing lipids.
Starts broad atherosclerosis as a global killer. Major risk factors including hyperlipidemia. Key point.
Lowering LDL saves lives.
Absolutely fundamental. The chapter then gives a quick history of the guidelines from ATPI to 3.
Focusing more on LDL and HDL than bringing in Framingham risk, identifying PA as a CHD equivalent.
Right. Then mentioning the shift with the 2013 and 2018 ACC guidelines, focusing on statin benefit groups, less on rigid LDL targets for everyone, and incorporating newer drugs like PCSK9 inhibitors.
How about trials specifically in PA patients?
Important ones are mentioned. Early hints, then the 4S study showing benefit for claudicants, and the heart protection study, HPS, which was a landmark trial showing major benefits of statins in PA patients.
Good evidence base there. Then it dives into lipoprotein metabolism. Sounds complex.
It is, but the chapter breaks it down. Exogenous pathway, dietary fats, chylomicrons, endogenous pathway, liver-making, VLDL, IDL-LDL.
Role of enzymes like LPL. Yep. And hepatic lipase. And it points out which particles are really atherogenic, the chylomicron remnants, IDL, and especially LDL, plus HDL and reverse cholesterol transport.
The good cholesterol pathway, and the basic process of atherosclerosis.
Endothelial injury, LDL gets in and gets oxidized, monocytes stick and become macrophages, eat the LDL, become foam cells.
Leading to intima thickening, plaque formation, stable or unstable.
And crucially, it's the same basic process whether it's in the coronaries, carotids, or peripheral arteries.
How do we diagnose these lipid disorders?
Screening is key, based on ATP 3 recommendations. Lipid panel, total cholesterol, LDL-C, HDL-C, triglycerides.
And it mentions that atherogenic dyslipidemia pattern again, common in diabetes and metabolic syndrome.
Yeah, the high triglycerides, low HDL, often with small, dense LDL particles, even if the standard LDL-C number isn't super high.
Yeah.
Measuring LDL particle number, or ApoB, might be useful sometimes.
What about non-drug therapy?
Always the first step. Diet changes, less saturated fat, less dietary cholesterol, cut out trans fats, more plant sterols, more viscous fiber. Table 13.6 has details.
And exercise.
Definitely helps. Moderate activity, aiming for about 200 kcal burned daily, can lower LDL and triglycerides, raise HDL, improve insulin sensitivity.
But often, drugs are needed. Statins are king.
Statins are the first-line pharmacotherapy for LDL lowering, yes. They inhibit HMG-CoA reductase in the liver. Table 13.7 lists the different ones and doses. HPS show their power in PA.
What about the other drug classes?
Briefly mention niacin, fibrates, bile acid sequestrants, ezetimibe, omega-3s, PCSK9 inhibitors, bempedoic acid, but the emphasis is clearly on statins first.
Though ezetimibe and PCSK9s get highlighted for adding to statins in very high-risk cases.
Correct, based on the 2018 guidelines. And combination therapy might be considered if triglycerides are still high or HDL low despite a statin, especially in high-risk folks.
The chapter includes some management algorithms, too.
Yeah, guiding treatment based on ASCVD risk level, very high, versus not very high, emphasizing high-intensity statins, and when to consider adding ezetimibe.
Okay, good overview. Let's hit chapter 14. Hypertension, high blood pressure.
Another incredibly common problem. Nearly half of U.S. adults, based on the newer 2017 criteria, leading cause of CVD death, second only to smoking for preventable deaths.
And again, disparities. Higher prevalence with age, higher in Black Americans.
Right. And women and Black Americans seem to have higher risk of CVD events related to their hypertension.
How does it link specifically to different vascular diseases?
It's interesting. Higher diastolic pressure seems more linked to AAA development. Higher systolic is more strongly tied to stroke, MI, angina, and PD.
Framingham study showed that PAD link.
Yes, higher PAD risk with higher SBP and DPP. But overall, systolic pressure seems to be the strongest predictor for most CVD, including PAD.
And the diagnostic criteria have changed.
They have. The 2017 ACCT guidelines lowered the threshold for diagnosing hypertension compared to the old JNC7 report. Important to know these current definitions.
Different from European or UK guidelines, too.
Slightly different thresholds and recommendations, yeah. Diagnosis usually needs multiple readings over time. Ambulatory monitoring can be useful, too. And they updated the definition of resistant hypertension in 2018.
What about the mechanism? How does HTN drive atherosclerosis?
It's complex. Genetics, lifestyle, environment, other conditions all play a role. Endothelial dysfunction is definitely part of it.
Management goals are straightforward, though. Lower BP, reduce CVD risk.
Exactly. Through lifestyle changes and medications. The 10-year ASCVD risk score helps decide who needs meds for stage 1 hypertension.
What are the key lifestyle changes? Table 14.6.
Weight loss, the DHH diet, sodium reduction, potassium supplementation where appropriate physical activity, moderating alcohol, all have estimated BP lowering effects listed.
And meds. What are the first-line choices?
4 main classes: thiazide diuretics, calcium channel blockers, CCBs, ACE inhibitors, and ARBs. The choice depends on the patient age, other conditions, adherence, cost.
Any standouts from trials like all a hat?
ALHAT showed chlorthalidone, a thiazide, might be slightly better for preventing heart failure. It also suggested ACE inhibitors might be less effective in Black patients for preventing heart failure and stroke.
What about starting therapy? Stage 2 usually gets 2 drugs.
Often, yes. Start with 2 first-line agents if BP is significantly elevated. Need to be careful about hypotension, especially in the elderly. And don't combine drugs from the same class like an ACE and an ARB.
How about choosing meds with specific comorbidities, like ischemic heart disease or diabetes?
Yes, there's guidance. Beta blockers, usually not atenolol, for stable ischemic heart disease.
Yeah.
ACEs or ARBs for CKD or diabetes with albuminuria, but careful with bilateral renal artery stenosis.
And for PAD specifically.
No single agent is proven superior for the P8 itself, so you choose based on the patient's other conditions.
The chapter also lists details on all the drug classes, mechanisms, side effects in Table 14.7.
Correct. Thiazides, loops, potassium-sparing diuretics, beta blockers, ACEs, ARBs, CCBs, alpha blockers, central agonists, direct vasodilators. A quick review.
And algorithms for initial therapy based on stage and comorbidities.
Yep, helpful flowcharts there.
Okay, quick mention of Chapter 16, Persistent Organic Pollutants, POPs.
Right, just a brief note based on National Academy's reports.
Key finding related to Agent Orange.
The evidence linking it to hypertension is now considered sufficient, and limited or suggestive evidence for type 2 diabetes, ischemic heart disease, and stroke. Something to be aware of.
Good to know. Finally, Chapter 17. This takes a broader look, international and ethnic trends.
Super important perspective. Globally, atherosclerosis drives IHD, stroke, PAD, and the burden is growing, especially with rising smoking and diabetes rates in many parts of the world. Needs a multi-level approach.
What are the big international risk factor trends?
Tobacco use has declined overall, but big regional and gender differences remain. Southeast Asia is still high. Diabetes prevalence has exploded globally, particularly in Western Pacific and Southeast Asia. That's going to drive more vascular disease there.
How about IHD and stroke trends globally?
IHD is everywhere. Incidence of MI and prevalence of angina HF fell in many places from 1990 to 2010, but not Eastern Europe initially, though mortality there has improved recently, likely due to better treatment. Stroke incidence is high, especially in Asia and Europe. It decreased in high-income countries, but increased in low- and middle-income countries, LMICs. Stroke is the second biggest killer globally, mostly in LMICs.
And PAD globally.
Affects over 200 million, mostly in LMICs. Prevalence has risen everywhere, highest in the elderly. Incidence highest in Western Pacific Southeast Asia, LMICs. Mortality is lower than IHD stroke, but still a major challenge, especially in LMICs with limited resources.
Now shifting to ethnic trends within the U.S., big demographic changes happening.
Huge. Decreasing proportion of whites, increasing Hispanic and Asian populations projected by 2050, and psychosocial factors, nutrition, healthcare access really impact risk across groups.
What are the key risk factor disparities? Obesity.
Highest in non-Hispanic Blacks and Hispanics, lowest in Asians, though BMI cutoffs for risk might differ for Asians. Diabetes prevalence increased similarly across groups, but Asians might have higher likelihood after adjusting for other factors.
Hypertension.
Highest prevalence in Blacks, lowest in Hispanics. Awareness, treatment, and especially control show significant disparities. Blacks have high awareness treatment but lag in control. Hispanics have the lowest rates across the board with little improvement in the disparity.
Cholesterol.
Prevalence highest in whites, but checking and treatment rates are lower in Blacks and Hispanics, leading to worse control, even though medication use is similar once diagnosed. Smoking rates decline, but disparities persist highest in American Indian Alaska Natives, lowest in Asians.
How do these risk factor disparities translate to actual vascular diseases?
We see it across the board. Cerebrovascular disease. Disparities in incidence, treatment like thrombolysis rates, potentially linked to access, PAD, highest prevalence in Blacks, higher diagnosis rates in diabetic Blacks, differences in treatment patterns, like fewer endovascular procedures for Black patients with claudication.
And outcomes.
Some data suggest higher early graft failure and worse long-term patency after bypass in Black patients, possibly due to more aggressive neo-intimal hyperplasia, though the reasons aren't fully clear. Biology versus other factors.
Aneurysms, dialysis access.
Lower screening and repair rates for AAA in Black and Hispanic men. Disparities in EVR outcomes. Lower rates of AV fistula creation for dialysis in Black patients.
It's a complex web of issues. How does the chapter suggest addressing these disparities?
It calls for multifaceted strategies. Policy level, tobacco control, healthy food policies, urban planning for activity, healthcare level,
Mm.
better disease management programs, culturally confident care, addressing socioeconomic barriers like poverty and insurance, and tackling provider bias.
A huge undertaking.
Absolutely. So wrapping up our deep dive into this section of Rutherford's, the takeaway really has to be that managing these atherosclerotic risk factors is just fundamental to everything we do.
Yeah, you can't be a vascular surgeon without being deeply involved in managing smoking, diabetes, lipids, hypertension. Staying current, like through resources like Rutherford's, is non-negotiable for good patient outcomes.
hmm This overview hopefully provides a solid foundation, covering the key points from these chapters.
Mm.
But obviously, the textbook has much more detail for specific situations.
Definitely encourages going back to the source. So maybe a final thought to leave our listeners with. Given everything we've discussed, especially the global burden and the stark ethnic disparities,
Yeah.
how can we, in our day-to-day practice, really operationalize this? How do we best weave these comprehensive risk factor strategies into busy surgical clinics and hospital workflows to actually start moving the needle on these disparities?
That's the critical question, isn't it? Something for all of us to think about constantly.
Indeed. Well, thanks for joining us on the deep dive.